Hypertensive nephrosclerosis. Hypertensive nephrosclerosis is a significant cause of chronic kidney disease, accounting for approximately 25% of all cases. The key mechanism involves long-standing hypertension leading to fibrosis and sclerosis of the renal vessels, resulting in progressive kidney damage. Management involves strict blood pressure control, with a target systolic blood pressure of less than 120 mm of mercury, using medications such as angiotensin-converting enzyme inhibitors, ACEIs, at doses of 10 to 20 mg of lisinopril daily. Key points. Note: hypertensive nephrosclerosis affects approximately 10% of the general population, with a higher prevalence in African Americans, 16.5%, compared to Caucasians, 8.5%. The disease is characterized by a gradual decline in glomerular filtration rate, GFR, of 2 to 5 ml/min/1.73 mmHg per year. Blood pressure targets are set at less than 120/80 mmHg, with a diastolic blood pressure goal of less than 80 mm of mercury. ACEIs, such as lisinopril, are recommended as first-line therapy at doses of 10 to 20 mg daily. Calcium channel blockers, CCBs, such as amlodipine, are used as second-line therapy at doses of 5 to 10 mg daily. The use of diuretics, such as hydrochlorothiazide, is recommended at doses of 12.5 to 25 mg daily. Serum creatinine levels should be monitored every 3 to 6 months, with a target level of less than 1.2 mg per deciliter. Proteinuria is a significant predictor of disease progression, with a target level of less than 1 g/day. Overview and epidemiology. Hypertensive nephrosclerosis is a leading cause of chronic kidney disease, CKD, accounting for approximately 25% of all cases. The disease is characterized by a gradual decline in kidney function, resulting in end-stage renal disease, ESRD, in advanced cases. The incidence and prevalence of hypertensive nephrosclerosis vary by demographic factors, with a higher prevalence in African Americans, 16.5%, compared to Caucasians, 8.5%. Major risk factors for the disease include long-standing hypertension, diabetes mellitus, and a family history of kidney disease. The disease is more common in individuals over the age of 50, with a male-to-female ratio of 1.5 to 1. Pathophysiology. The pathophysiology of hypertensive nephrosclerosis involves long-standing hypertension leading to fibrosis and sclerosis of the renal vessels. The increased blood pressure causes endothelial damage, resulting in the release of inflammatory mediators and the activation of fibrogenic pathways. The molecular basis of the disease involves the upregulation of genes involved in fibrosis, such as transforming growth factor beta, TGF-beta, and platelet-derived growth factor, PDGF. The disease progression is characterized by a gradual decline in GFR, resulting in CKD and eventually ESRD. Clinical presentation. The clinical presentation of hypertensive nephrosclerosis is often asymptomatic, with patients presenting with signs and symptoms of CKD, such as fatigue, weakness, and edema. Physical signs may include hypertension, left ventricular hypertrophy, and retinal changes. Typical symptoms include nocturia, polyuria, and proteinuria, while atypical symptoms include hematuria and flank pain. Red flags for the disease include a rapid decline in GFR, significant proteinuria, and the presence of other systemic diseases, such as diabetes mellitus. Diagnosis. The diagnosis of hypertensive nephrosclerosis is based on a combination of clinical, laboratory, and imaging findings. The diagnostic criteria include a history of long-standing hypertension, a decline in GFR of 2 to 5 ml/min/1.73 mmHg per year, and the presence of proteinuria. Laboratory findings include a serum creatinine level of greater than 1.2 mg per deciliter, a blood urea nitrogen (BUN) level of greater than 20 mg per deciliter, and a urine protein to creatinine ratio of greater than 0.5 g/g. Imaging findings include renal ultrasound showing reduced kidney size and cortical thickness, and renal biopsy showing fibrosis and sclerosis of the renal vessels. Management and treatment. The management and treatment of hypertensive nephrosclerosis involves strict blood pressure control, using medications such as ACEIs, CCBs, and diuretics. First-line therapy includes ACEIs, such as lisinopril, at doses of 10 to 20 mg daily, with a target systolic blood pressure of less than 120 mmHg. Second-line options include CCBs, such as amlodipine, at doses of 5 to 10 mg daily, and diuretics, such as hydrochlorothiazide, at doses of 12.5 to 25 mg daily. Special populations, such as pregnant women, individuals with CKD, and the elderly, require careful consideration and dose adjustment. The American Heart Association, AHA, and the American College of Cardiology, ACC, recommend a blood pressure target of less than 120/80 mmHg, while the European Society of Cardiology, ESC, recommends a target of less than 130/80 mmHg. Complications and prognosis. The complications of hypertensive nephrosclerosis include CKD, ESRD, and cardiovascular disease. The incidence of CKD is approximately 10% per year, while the incidence of ESRD is approximately 2% per year. Prognostic factors include the level of proteinuria, the rate of decline in GFR, and the presence of other systemic diseases. Referral criteria include a decline in GFR of greater than 5 ml/min/1.73 m/2 per year, significant proteinuria, and the presence of other systemic diseases. Special populations and considerations. Special populations, such as pediatric patients, geriatric patients, pregnant women, and individuals with comorbidities, require careful consideration and dose adjustment. Pediatric patients require careful monitoring of blood pressure and kidney function, while geriatric patients require careful consideration of comorbidities and polypharmacy. Pregnant women require careful monitoring of blood pressure and kidney function, with a target systolic blood pressure of less than 120 mmHg. Individuals with comorbidities, such as diabetes mellitus, require careful consideration and dose adjustment. Clinical pearls. Note: hypertensive nephrosclerosis is a significant cause of CKD, accounting for approximately 25% of all cases. The disease is characterized by a gradual decline in GFR, resulting in CKD and eventually ESRD. Blood pressure control is critical, with a target systolic blood pressure of less than 120 mmHg. ACEIs, such as lisinopril, are recommended as first-line therapy at doses of 10 to 20 mg daily. Proteinuria is a significant predictor of disease progression, with a target level of less than 1 g/day. The use of diuretics, such as hydrochlorothiazide, is recommended at doses of 12.5 to 25 mg daily. Serum creatinine levels should be monitored every 3 to 6 months, with a target level of less than 1.2 mg per deciliter. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.